We'll talk quite a bit here today about medical stop loss, large claimants, the risk coverage, and dynamics to be wise to. Hopeful we're a little bit past the post-lunch, phase where if you have a caffeinated beverage or not that, but hopefully it's engaging enough, revealing enough. And two, as was described, a broker and consultant on medical stop loss. We are not an underwriter. We don't carry the risk. We place the risk on behalf of plan sponsors, employers, and other groups. We work direct with employers, or we work oftentimes alongside another consultant or broker who has raised their hand and say, this stuff is kind of tricky. Can we kind of plug you in on our bench? And so that's another way we commonly interact. But what I think too in this format today is also a good way, and maybe there's some candid commentaries of my own about the marketplace that's out there. And I don't think that's oftentimes heard enough out in the marketplace. So I'm eager to share some of those viewpoints. I'm not going to be pointing fingers at anyone or any entities. Well, I might a little bit when we get into it. But, I am very open as we go along, and if there's a concept I've covered that wasn't explained too well or kind of still unclear, shoot your hand up. I'm good with questions as we go along. And as I was sharing with some others earlier ahead of this, because I'm just as eager to hear what the audience might observe or say or have heard. This is kind of a two-way street, actually, and this is why it's a great platform, because I'm eager to hear what maybe you've heard or been wondered about or been told by another or experienced on your own plan with a catastrophic claimant. Real quickly, that good old show of hands, who has either a plan with stop loss or has it on their plan or interacts with the coverage? And so we've got some, okay, then that's about right. I wasn't expecting to see, just like the caregiving question earlier, which got a lot of hands, expecting to see a tremendous amount, but too, it's something we can all kind of learn a bit more on. Really, there's three key components today. Started to go into that. Initially, an awareness of those current and evolving catastrophic claimants that are in the marketplace. And financially, and a lot of this is financial. We're not really kind of getting into the clinical. I'm a risk guy. I'm not a clinician. I'm not an MD or a PharmD or that. So I know the names of a lot of the things. I know the billing practices on a lot of these, so that's a little bit more of the slant here. But we're particularly looking at $1 million or more, because that is where a lot of the fear rightfully placed in the market exists, and is what's directing a lot of the coverage and stop loss in other vehicles that's occurring. Who are they? What are they? I mentioned inpatients, newborns, gene therapy. Is there also a little bit of coziness in the marketplace? That might be where some of the finger pointing happens. We'll also kind of share with you that they're young. I think there's a lot of time a sense that high claimants are those with poor lifestyle and wellness choices. Really not at all. They're almost reverse lottery picks. It's a lot of young. You just wind up with that claimant in your population. With that established, we'll talk a little bit more about understanding the risk. You saw that word, it's in the name of the business. This is a risk. We'll go in, it's not an employee benefit. It doesn't cover the employee, it covers the plan. And that's a very unique distinction. You, the plan sponsor, are the policyholder on this coverage. And so, and dynamics related to that. We'll talk about policy provisions. We'll show some benchmarking. We're proud sponsors of a survey every year that is somewhat crowdsourced amongst employers and the industry as a whole on medical stop loss premium. We do it in conjunction with the ISCBS as well. You're going to have a QR code for it. I do have some copies up here on the table up front if afterwards you want to get a hard copy of it. But it's a really great benchmarking tool. I know with Employers Health in prior years, we've had a separate reach out to offer participation in the survey. And hopefully we got several people here who have been able to use that before. But we'll show some key findings on premium cost, premium expense, coverage provisions. We'll also talk a good bit about, there's a lot of questions about, gene therapy carve-outs, other carve-outs, captives, other types of ways to access the coverage. And so we'll discuss those a little bit so we can all leave here a little bit better armed on where and when might those be a proper solution. And then finally, the actions. And when the rubber hits the road, what can you do on your next placement or your next renewal to ensure that your plan has the best coverage possible, and where to be careful to make sure you don't leave a gap in your coverage. So If that sounds good. $1 million claimants, who are they? $1 million plus claimants, because $1 million claimant actually isn't all that uncommon anymore. And first of all, a lot of this is now really the full roll-up of what happened when the Affordable Care Act was passed. Because those of us who were around, it's a valid question to comment on, because it has been some time, 2010, if I'm not mistaken, when the ACA was passed. You know, there used to be, generally speaking, a lot of plans had a lifetime limit of perhaps $1 million. $1 million claimant was very rare. The billing practices at hospitals and elsewhere kind of knew, hey, we're only going to get about we're going to get $1 million out of this claimant. So rare were the conditions that kind of got you up to that $1 million level. But stop loss as a whole, our survey had actually started back then. Probably 70% of the policies had a $1 million limit because that's what the underlying plan covered. The ACA removed lifetime limits. It took a few years for hospitals and health systems, therapy manufacturers, drug manufacturers to kind of look around and say, ooh, hey, we can bill $1.2 million for that 90-day hospital stay. Well, let's try and see what happens. Ooh, we got paid. And it gave that runway to, hey, orphan conditions with rare conditions without a whole lot of volume. Can we create a therapy that's going to have a sizable price tag to it? Will it be supported by the market? Which means by the market means either an employer health plan, perhaps a governmental health plan. But that's another missing part about all this, the pressure that's being placed on employer-sponsored healthcare right now. A lot of these larger ticket, high dollar claimants are on your plan. So, the conditions we have, congenital anomalies, that's kind of indicating those younger patients. Blood disorders, hemophilia has always been one. Actually, hemophilia claimants and their families, their caregivers, were actually a big driver behind the removal of lifetime limits at the time of the Affordable Care Act, because the cost for a Factor VIII claimant back then was already pushing $700,000. So you get a 14-year-old adolescent male in your plan, and now with the ACA, chances are that dependent is not going anywhere until age 26, because that parent knows they've got coverage, so that could quickly accumulate, and that was a big driver behind the removal of lifetime limits. We've got gene therapies, obviously already mentioned. We'll go into that a bit more. But what are some of these other $1 million trends that we're seeing that's giving proof in the marketplace that these claimants really are increasing? There's a really good report from Sun Life, who is one of the largest stop-loss reinsurers in the country, one of the largest books of business, every year, and they're about 2 weeks away from releasing it. So I wish I had it now. I reached out to our Sun Life representative, said, what do you got? He says it's not ready. So, okay, well, we've got, it's a report from last year. I got a couple tidbits that might be coming out. But, they're increasing. Their $1 million claimants have gone up 15% since 2022 and 45% from 2019 through 2022. So they're occurring. Now, first of all, when we look at that, when I look at that, trend itself is going to cause that claimant, that $950,000 claimant, and next year is probably going to be $1 million, and you're going to have more and more. So that is definitely a driver to any time you put a fixed dollar limit. We're actually going to talk about that with your stop-loss deductible, about that same leverage trend. But for the past several years, about 20% of their policyholders did incur a $1 million claimant. One tidbit he did share with me in that report, it goes further into it, they had 18 $3 million plus claimants in 2022. That number increased to 35, almost a doubling in 2023. So even at that higher level, and we have seen it in our client populations, we have seen the past couple of years an inpatient bill, well, over $5 million paid. Billed at around $9 million, paid at $5 million for lengthy inpatient stays. So we've seen plenty of them ourselves. And then curious dynamic too, to kind of give you a sense of who is this really large claimant. I had never seen them report this out before, but it agrees with what we've seen. 70% were a first time. I sometimes call those a pop-up claimant. And 30% of them were recurring. The Factor VIII hemophilia I talked about is a great example. Some of these other drug and therapies that are coming to the market do have those price tags, which can cause them to be a stop-loss deductible hit year after year, which asks the question about lasering and coverage, which we'll dive into a bit later when we talk about where the actions you can take. Another area, too, is the lengthy inpatient stays as well. I just made a mention to having a couple claimants that were over $5 million billed. Those are full quality PPO claimants. There was no network issue here, but generally a lot of times we see them in children's hospitals, nonprofit children's hospitals, and perhaps we have representatives from here, and that's great. They do wonderful work, but the claimants we see at some of those nonprofit children's hospitals, I mean, they do have some claimants that can be there for a lengthy period of time, but they are just immense. And it gets to a point in time where what we see too, since it triggers an outlier provision in the network provision, we have seen, I just saw one recently where it was something billed out at $700 and some $1,000 and the paid amount was around 500 or so. And I just pulled out my calculator because I was like, seems about right. And it was exactly 0.80000. That claim adjudication was simply what they got since they were in the outlier provision at 80%. It was paid at 80%. We asked some questions about it. We weren't able to get too far on that. So that's not as much I don't want to say that's a complaint about the system. It's just be aware of the system and how some of those claimants get paid out. And two, we do see at times with the ASOs, and we don't want to name names, but there's not that many large ASO players out there. And for some, we are seeing when we have those situations, the issue that first comes up is, well, we have a prompt payment provision with our provider. We need to fund this claim in the next 7 days. And we're asking, can we look at billing details? Can we do a review of the claimant? Oftentimes, and perhaps some of you as well, you hit a wall where you're not able to look at it because that's when you quickly find out some of the payers are a lot more provider-facing than they're employer-facing in that moment. It is what it is, and we'd like to try to improve it, but again, we're just kind of speaking to some of the dynamics in the market and what is stacked up against employer plans when they do incur one of these larger claimants. And getting a little more detail into those $1 million plus claimants. Again, this is from the Sun Life report, and it gives some background to the fact that they're younger. You can see in the graph here in the blue and the top bar, those are claimants under age 2. So in the $1 million category, over 25% of their $1 million plus claimants are under age 2. They're otherwise only 9% of their entirety of their book of business. Flip it down to the older category, over age 60, they're just 12% of the $1 million plus claimants, but they're 23% of the overall claimants. So as we said before, don't have a mindset that perhaps wellness is a key or a similar type of plan or member choices and lifestyle decisions. A lot of these claimants are just congenital anomalies. They're birth conditions, they're inherited diseases. So it's going to lend itself more towards the younger age. Rare diseases and orphans. So as many of you probably know, an orphan disease is a term developed some 40, 50 years ago, is a condition that has generally less than $200,000 individuals with that condition. So it's a rare disease in that way. And traditionally, because of that smaller population, there wasn't really much of a market for drug manufacturers to develop therapies to that. There was actually an attempt with the Orphan Drug Act, which came out, I believe, in the 80s, to try to change around that, but it hit the wall with the fact that the financial runway to bring such a therapy to market for such a small population required such a large outsized price tag. The ACA removing limits kind of opened that up. The pharmaceutical world is eagerly pursuing those regimens. I'm always cautious with this audience, particularly when I start to wade into pharmaceutical and drug, because there's a lot more in the audience who are definitely more sharper than me. But a lot of your lifestyle conditions, if you will, your blockbuster drugs that we're all familiar with, that we see, have seen advertised, or have now been in generic. There's not a whole new cholesterol reduction. There's not a whole new drug coming to market with the advertising scheme. It is these rare diseases. And what pharma has done, or biotech, whatever, to do is they have now seen the price tags and the possibility for the cost of these drugs and seized upon it. they are coming with very large costs to these drugs. It is not necessarily because they're trying to recoup research and development. A lot of these therapies are developed in joint with the NIH and other governmental therapy. They just realize what the pricing mechanism is. They have bought perhaps a biotech in the billions of dollars to now acquire this drug that's not even to market. And simply put, they are looking to recoup their investment with the price tag that they earlier were seeking. And a lot of times there's different ways. A lot of these price tags for these very sizable drugs will take Roctavian, which is for a factor VIII hemophilia, where right now the annual therapy cost for a factor VIII hemophilia could be from $750 to approaching $2 million a year. The dosage of a Roctavian therapy is at $2.9 million when you get that. It is theoretically going to largely remove the need for annual factor administration. But largely what has happened there is there's been analysis to realize that, hey, the net present value right now of those future annual expenses, to put it to the market, comes out to be about $2.9 million for a one-time administration. So that is really where a lot of the pricing on some of these higher dollar gene therapy drugs have been developed and are formulated. I give an example right there with the net present value. So what's really happening here, and it gets down to what is the underlying risk with any catastrophic claimant. Now, is that it's a risk very low in frequency, but very high in severity. And that's exactly what stop loss has always been designed to protect the plan against, is that infrequent, unexpected claimant, and for the variable cost that that claimant might incur. So let's kind of look a little bit more at the underpinnings of stop loss. So this is a good time to, I've already tried not to drop too much jargon on stop loss here, but we've got the quick primer slide to get everyone up to speed if you're still aren't up there on stop loss. But really, you've got two types of stop loss. You got a specific stop loss and you have aggregate stop loss. The stop loss, which is where when the occurrence of a claimant passed the policy deductible. It could be $50,000 if you're smaller. It could be $100,000. It could be $500,000. It could be $1 million. We have a client that has $1 million specific deductible. They have 17,000 employees. They can readily take the first $1 million. And so, but that is what's specific. And anytime there is stop loss, specific stop loss is almost entirely present. What could also be alongside, and it's more for smaller groups or groups that have recently gone off of fully insured, is aggregate stop loss. Aggregate stop loss is much less expensive, and it's designed to be for the overutilization of the plan. It's rarely hit. It's typically at 125. What's your ag at? 125. That's our survey measures that. That's the most common provision. So, you have to be 25% off of budget to hit an aggregate stop loss hit. A lot of times it just has $1 million maximum reimbursement, which you've probably already blown your budget by several $1 million if you're hitting the 125. But there still is it's sort of a belt and suspenders approach. There are a lot of groups, particularly as they roll off a fully insured setup, a CFO or a treasurer who really wants to make sure they have that aggregate stop loss coverage in place, and it really buttons up the whole plan. So hopefully that helps clarify that a little bit with some of the audience. What we say too with stop loss, I alluded to this earlier, it is a risk, not an benefit. It covers the plan sponsor. Again, your plan is self-funded and therefore is the entity at risk. Unlike your claims payer who is facilitating the funding of claims. Now you can get stop loss with your larger, with the Blue Cross, United, Cigna, Aetna. They all readily market stop loss and do a good job of it. And it's quote unquote seamless when they do it, because when you have a claimant that goes past the deductible, they just take money from the stop loss account to help fund that claim. There is a much more vibrant third-party stop loss is where I mentioned Sun Life. You got Voya, HM, some of the other underwriters out there, HCC, there are some of the bigger names that you can place your coverage. And what you do when you have that is you also have a sentinel effect. Because with the seamless stop loss, it's great, it just wires it over, but you may have a claimant that you aren't getting full reporting on. If a tree falls in the forest, no one was there to see it. You're going to see it in your claim reports eventually, but with external stop loss, you do get much more transparency on the occurrence of your high claimants. And you have another set of eyes who's rightfully double checking to make sure that was a valid claim, that fits your plan document, and that is rightfully covered by the stop loss. And referring to that, since it is a coverage for the plan sponsor, it is very key to have integration between your stop-loss policy and what your plan documents as a covered expense. That's the rule book, just like we all know with our plan. What is a covered expense? Well, is it in the plan document? Let's go take a look. That is what your stop-loss carrier, they need a copy of the SPD when you place the policy. That is what claims has on hand to judge whether or not it is a covered claim. Now, a key issue we want to be careful about, though, is that your stop-loss policy will have a separate definition of usual and customary, for instance, as will your plan document. So you want to make sure you don't have two different entities saying, that's not really usual and customary to us. We don't care if Blue Cross said it was. We don't consider that usual and customary. So it is advisable to always make sure you've got some plan mirroring is the term, and that's where your policy can basically say, hey, we're going to delete our definition of these terms and use that of the underlying plan document. So you remove that potential conflict. There's a first good takeaway there. Just make sure as much as possible you have plan mirroring, because particularly when you get into a very large claimant, and depending on who your stop-loss writer is, you could potentially have a conflict that was best avoided if you did not have that situation in the first place. We also want to be careful at placement of the coverage when you're placing it, even when you're renewing it, when you're getting market bids. As we said before, it's a risk. The stop-loss underwriter wants to know, hey, who's in your plan right now? We want to see a list of high claimants so we know what's coming our way. And can we get some details on these additional claimants? Unfortunately, they're underwriting the risk. They want to see what's coming their way so they can make sure they don't have an incoming potential claimant, a transplant, a factor 8 that could be a candidate for Roctavian coming at them, using that one before. So you have that disclosure process. It's there. Make sure that's done properly. Oftentimes for many groups, it's, hey, can we get it's the January 1 renewal. We want to see your high claimant listing through September 30th in order to firm our renewal based on that September list. Make sure that list is complete. You're not leaving out a subgroup or a subgroup covered by the policy that has a separate administrator, or an acquisition you've rolled into your coverage that needs to be disclosed. Have that fully disclosed. It's simple, it's blocking and tackling. But if you leave a group or a claimant non-disclosed that should have been disclosed, and that claimant hits, let's say February, March, the first thing they're gonna do is say, ooh, was that on the high claimant listing? And ideally they see and say, oh, sure enough, it was there. We didn't take any action on it, or that was a risk we knew was coming. If they don't see it and they're sitting there going, hey, that's actually, wait, why did we not see this? We see in the history from the notes we got that there was already some clinical episodes back in August, September. Again, if they accepted the list, let's say it was based on claimants above 100,000 and that claimant was only at 75,000, you're gonna be good because they accepted that list above 100,000. But disclosure, again, that's where it's a risk, not a benefit. And in the property casualty world, you have a lot more of this dynamic, so be very aware of disclosure and what that entails. And particularly, ensure that your advisor is astute to what's going on there. Let's take a look at our survey a little bit more. So, and hopefully, the fonts on the axis are just enough to see there, or you can zoom in on the presentation. You can electronically access. There is no average cost for stop loss. Stop loss premium varies by the size of your deductible. So what we're doing with this right here is showing the continuum of stop loss premium expense. On the far end of the horizontal axis, you can see we've got 100,000 as the first line. Goes to 200, 300, 400, 500. So, and the premium, the per employee per month is on the vertical axis. So obviously, if you have starting to the left of 100,000, if you have a $50,000 deductible, we've got some up there. We're going to have some more beyond the range of this graph. You have some of those dots where you are paying north of $300 per employee per month for that stop loss premium. It dives steeply as you come around the curve and go to 300, 400. So you can see it's around $60 as we hit around 350,000 on this. We've got two lines up there because we always show what's an anticipated impact of next year's pricing trend to get you to the next level. So this is the 2020 2023 survey. That's the bottom line. The blue line is an impact of next year trend, which we value at 13%. Why that high? Because we have leveraged trend. Just like when you had a fixed dollar copay with your pharmacy back several years ago, if it stayed at $10 for the employee, but the $100 drug went up 20%, employees still paid $10, but you, the employer, went from paying $80 to $100. It had a nice 20% plus premium trend or a cost trend. The same dynamic happens with stop loss. So as I said, I'm going to have a QR code coming up here too where you can grab it. But hopefully on your presentation, you can zoom in closer or grab one of the copies there. But that's always a good elusive set to kind of see where you're at in the market. And what we enjoy about this one too, this is not as much a pricing measurement. This is actual market. This is placed coverage. This is reflective of negotiations and final settlements. So we actually have several underwriters who are very cued in. We actually had one commenting right before the session here who has participated and looked at the survey in the past. And we say too, it's a good reflection of the negotiated premium amounts. And you can obviously have some variability there. We talk about that as well. It's if you're a group that has a lower cost premium, it's likely indicative that you're purchasing more efficiently. Perhaps you have a healthier population. It can also just as much, we're really unable to pull it out and have it to be a timely survey, but it may also indicate you have a higher single content, for instance. But it gives you that directional insight on where the cost may be. Alongside that, and again, apologies for the access perhaps not being, this is how, a common question is, hey, we're 1,500 employees. What should our stop loss deductible be? Well, that's sort of a nuanced story. What's your favorite flavor of ice cream? Well, it depends. If it's in a banana split, if it's in an ice cream cone, if it's really hot, if it's cold. But it's your own risk tolerance. But this is an elusive graph we have here, but again, the vertical axis is the number of covered employees. We've got it marked off by the thousands, and the deductible is 100,000, 200,000. So you can see a 1,500 life employee, but you can see, actually, let's use 2,000. 2,000 comes around, you start to see some groups that have it at around 175,000, that dot above it, but you've got several on both sides of the graph. You've got a lot of concentration at the lower end. You have more employers at that size, so that's why it's more concentrated. We also do have entries that are way outside of this, so we'll only fit the graph up until 750. But, it is, what's your risk tolerance? What have you had before? How much can your financial and budget take a large hit? But it gives a good indication there, at least in that, of where's a good point to have your deductible. So getting a bit into the coverage parameters here. Lasering, how many might have heard that term before? That's okay. Pretty much everyone who rose their hand before about stop loss is familiar with that term as well. A lasering, a claimant excluded from stop loss, either at placement or renewal, or how can they do that? And again, I'm not here to rationalize it or say, well, tough, deal with it. But I kind of am, because this is what the tricky part, because I said how some claimants can occur year after year after year. Stop loss, like any other insurance, is priced and designed to cover that future unknown risk. You've now caught this claimant. This claimant, yes, it's a high claimant, but as good as day for some of these diagnoses or therapies, it's going to be there next year, and based on their age, it's going to be there the next year. That, unfortunately, is no longer a risk. That is now a known expense of your health plan. So, but still, you're paying good money for the stop loss coverage. You don't want them at renewal to totally laser them out and exclude them. That is unfair. You didn't quite buy into that. And so with the market and that, many policies do have a no new laser at renewal. Further, they have a no new laser at renewal with a renewal rate cap to it, so that they can't say, well, we're not going to laser it, but we're going to double your rates 100% to make up for it. A lot of those caps might be at 40 or 50%. And actually, in the scheme of things, let's say you're a group with a $250,000 deductible. You catch a $1.5 million a year hemophilia claimant, that was a $1.25 million reimbursement you just got. That may have equated to what your annual premium was. So yes, they may hit you for a 50% premium increase, which will be $600,000 or so, but you're still getting a sizable reimbursement back. In many cases, even though you are suddenly stuck with an unfortunate situation on your plan with such a large claimant, but the renewal rate caps actually put you in a better position elsewhere because anyone else in the market is likely going to fully laser that claimant on placement. So they've kind of got you a little bit in a pickle there, but it is better than what would be if it is fully exposed to you at renewal. With no new laser, they've been around for several years, they're bandied about. There's slight differences. You don't quite, you got red apples and you got green apples in there. And so when they first came out, and some of the writers who more popularized them was some of the larger writers, they very much were somewhat in perpetuity, meaning if you caught one of these claimants I've been describing, yes, you may be subject to a high increase, but capped, but that person was stuck on your plan in many ways or stuck on your stop loss coverage. Now everyone, more or less in the language, is offering where it's good on the next renewal. It's your no new laser with renewal rate cap on your next renewal. So then when you do the renewal a year later, you're looking to continue that. They may raise it up a bit from 50 to 60, but be aware it is not in perpetuity. Really no one has it. Everyone has a way to get out of it, or if not pretty more directly say, look, this is good for another year. So please be aware of that. And finally, with that laser and with the claimant, be aware that we're having this conversation with a couple groups of ours right now who have some claimants which have been stuck on their plan. I hate to say it's stuck but that way, but financially it is. And where they're just realizing, look, we are paying premium, because right now the stop loss underwriter is taking that claimant, figuring out the future price of your risk, and then putting that claimant on top to get your final premium amount. So some groups, and there can be situations where that claimant rolls off of your plan, is no longer on your plan, but you are stuck on the premium. So it can be a potential situation where, as I put it, it's a brand new fixed cost of your plan. You can do a PEPM or a PEPM calculation, realize that to fund that claimant is an extra $10 per employee per month just to fund it, instead of have it on the stop loss. Hopefully you don't have too many of those, but there are ways to go around that and actually come out stronger. So don't be afraid to look at it from that perspective. Gene therapy. So many of us familiar, again, we're one claimant by itself. I gave you some of the price tags on that. There are right now close to, not necessarily all gene therapy, but close to 20, 25 therapies that are pushing $1.5 million or more that have already been FDA approved and more in the pipeline, which many of you know, where one claimant can be outsized to premium. So at time of placement, that is where hemophilia, it's an easy one to refer to, are going to get an extra scrutiny. If they get a sense, depending on your underwriter, that, this might be a Roctavian claimant, you are going to more likely see them in another therapy where that laser might be, we'll accept this claimant, but if there's a gene therapy, they may not even say Roctavian, but any gene therapy, the deductible will be $2.9 million on that claimant. And that's how some underwriters are approaching it at disclosure, to just exclude them when they can so they don't incur that claimant. What we're seeing in the market, though, is some of the larger underwriters, and that's an apt way to describe them because they're the ones more doing it, they're saying, hey, wait a minute. We're making a name for ourselves in this business on medical stop loss. We don't want to run from these claimants. This is kind of the business we're in. It's the business we've made. We can price for these. We can expect we're going to have, let's say 3 Zolgensma claimants on their $1.5 billion book of business next year. We'll price it into it across everybody. If you have Zolgensma, you have a claimant that needs Zolgensma, and you hit it, hey, we were going to have 3. You're one of them. Pay your claim. And that is really, the evolving approach as opposed to the cut it out, but just be ready to handle it. So be aware for that. I can describe more of that maybe separately, who we're seeing to do that. And some other things we talked you talked earlier about with any expense with your plan document, make sure it's medically reviewed and follows your plan document. That's especially keen for anything like a drug gene therapy, make sure you have strong vendors in place. Because it may not be aware at the stop loss writer that you had such a claimant till it's being presented for payment. And if you can show, hey, ideally you had them involved earlier, that, hey, it followed clinical protocols, it follows our plan document, the claim should get paid. We got some other quick observations here on the market. There's a lot of talk about gene therapy carve-outs. Do those make sense? In our sense, we haven't really looked down too much. We've kicked the tires on. I'll be honest. If you are a larger group and you have a strong stop-loss policy, your underwriters should be ready to accept this risk. You can carve it out with some of the options. A lot of the options that are on the marketplace are tied to a PBM, which then needs you to use that PBM in order to have the coverage. But if you're going to carve that out, your underlying stop-loss writer, who you're probably going to go to and say, hey, can we get pricing credit, is going to say, well, how much are you paying for that? Then we'll offset it. Well, 99 cents per member per month, that's the offset. And they are now going to write that off of the stop loss policy. There's no double indemnity here. So if you have a carve out like that and come back later and say, hey, we want it back into our policy, you have a whole new disclosure event. And I don't think that's being discussed a whole lot in this conversation about gene therapy carve outs. Captives are always being brought up. They have for many years. They make sense if you're a smaller employer looking to self-fund for the first time. It's hard to get stop loss at first. You can join a group captive setup in order to more collectively purchase in many ways and get into that. If you're a larger group, the stop loss market is still pretty dang efficient. It's a one-year commitment. There's not a whole lot of argument unless your CFO is saying, hey, we have to diversify our existing captive. It just doesn't make sense. It's kind of a buzzword. It has been for many years, but we just don't see it. Talked about the sentinel effect earlier. And then finally, stop loss has gotten to be pretty big business. It's a big, the market is actually growing. It was around 8 to 10 billion in 2010. I heard this in the recent presentation. Now around 32 billion. There's a lot of entities, brokers, consultants, other entities that really want to get in on that premium dollar. Hey, it's our business too. We've been doing this since 2005, but before all this growth happened. But just beware. It is, make sure you've got some expertise behind any of those approaches. So again, just some of those actions. We just said, seek a no new laser policy with a rate cap. Ideally, no. Let me get my. No greater than 50%. You can get 40%. If you're a large group, and let's say you're paying $1.5 million, $2 million a year as a stop loss premium, you should certainly be going for a 40% increase, because that's a lot of premium base to increase 40% to make up for that claimant. The 50% or even the 60% isn't really one size fits all. If you're a larger group, and I would say if you're paying more than $1 million in stop loss premium, you really should be going for that lower amount. Pursue the plan mirroring. Investigate a dividend contract. They're out there. They were kind of fashionable several years ago. If your claims to premium ratio is, let's say, usually it's formulaic, is less than 65%, you can get some of that money back in a good year. If you only paid out 50% of claims to your premium, you can get perhaps a quarter of that 15% if 65% is your target loss ratio, and get that back. And we have a lot of success with some groups who just purchase efficiently. You saw the curve. That's a collective pooled pricing. Everyone's off of that same curve. And our job is to kind of get you below that manual as much as possible. We can get you down around 70% if we're fortunate and you have the background, but to get it even lower, we need a dividend contract to hopefully get another 5 or 10% of your premium dollars back to really get some value. So look at getting a dividend contract if you don't have it. Finally, index your deductible every year. Not every year, every few years. If you keep it fixed, and we have a slide at the very end, it's in our survey too, leverage trend happens. It gets higher as the deductible gets larger. And so, the leverage trend, that's why you see renewals coming at you at 20% plus. That may be too high, but something at around 12 or 13%, all things equal, is actually a pretty good deal if you're not changing your deductible. But you could raise it every couple of years by 5%, and you're going to take away a lot of that extra premium increase expense, or save it for that rainy day year is how we instruct a lot of times. So just some more final actions we have here. Be mindful of your disclosure. We touched on that briefly. Be aware of what it does. Make sure it's done right and it fully captures everyone. Sell your risk. This is how the property casualty world works, actually. The benefits world doesn't. But if you've got a really good network, you've got a really good discount, your employees are really engaged in the health plan, and your claims experience shows it, sell it so you can get off of that manual rating, off that curve, and get below it as much as possible. Benchmark to make sure you're positioned well. And finally, as we, a little bit here, leverage expertise if you can get it from your own experience or from your advisor. It's a tricky coverage. It's its own nuance. There's a lot of claim dynamics coming at us, and it is a coverage where expertise can definitely help benefit you and your plan. So this is a summary again of our key concepts, which hopefully we covered a good bit of those. We've got a few minutes left for questions. There is the QR code that you can grab a copy as a web page, which then leads to a copy of the survey. I do have printed copies, which I can leave on the break up front here as well. And I mentioned too, I'm going to go back to that. This is contract terms. We didn't bother getting into that, but that's useful. That's where people can get very confused, 1218, 2412, 1212. And this is a leverage trend where you can see by the time you get to $400,000 deductible. This is from our survey. And so this is the market proven. Yep, sure enough, leverage trend is there. Almost a 15% increase annually over the past 2 years. Any questions or areas I might have gone over? Yes, and we got a microphone coming right to you right here.
You kind of touched on this, but I thought I'd ask it anyway. The place where I work in pharmacy, so
okay,
the place
yep.
where stop loss and pharmacy intersect is almost always gene therapy.
Sure.
And I get asked about it a lot because I'm in the pharmacy side, and my position has been that's a stop loss problem, not a pharmacy problem, like a risk management
and that's
problem.
fair.
Would you agree with that assessment? I'm curious.
Yeah, yes, because it all makes it down to who's paying it. But as I said, as a plan sponsor, make sure your plan document and your PBM, of course, a lot of this could be on the medical side, that it was clinically approved, proper, and certified before the dispensation or administration. So if that's done there and you have a good underwriter, which could be a whole separate topic, there are good ones out there, there's some squirrely ones out there too, it'll be paid. And at that point in time, you're right. And that's what stop loss is for. Don't worry, we got it covered. Good question. Mm-hmm.